So today we're going to talk about the knee, and I'm going to try to squeeze a lot of material into the amount of time that we have. So first, let's start by looking at the bones that make up the knee. The knee consists of three bones, basically: the femur, the patella, and the tibia. There's also a fibula, but it's not really part of the knee joint. So let's look at these bones individually. We're going to start with the patella. Patella comes from Latin meaning a shallow pan, and if we look at it from the side, it does kind of look like a shallow pan. The patella is the largest sesamoid bone in the body. A sesamoid bone is simply a bone embedded within a tendon, and there's lots of sesamoid bones in the body. Particularly, there's a lot of sesamoids in the foot. The great toe always has two sesamoids right by the head of the first metatarsal. About a third of the people have an os perineum. A lot of sesamoid bones. The patella is perhaps the most important. The patella is part of the quadriceps tendon. The quadriceps tendon consists of the four quadriceps muscles: vastus lateralis, medialis, intermedius, as well as the rectus femoris. And the tendon itself inserts on the tibial tubercle or tibial tuberosity. And all of this collectively makes up the extensor mechanism. But the joint itself underneath the patella is called the patellofemoral compartment. If we take out the patella and bend the knee, you can begin to see the articular surfaces inside the knee joint. What I'm pointing to here is the trochlea groove. Trochlea comes from Latin meaning pulley, and it's basically the femoral half of the patellofemoral compartment. If I put the patella back on top of it, you can see the relationship. Now, on either side of the patella of the trochlea are the femoral condyles. Condyle comes from Greek meaning knuckle, and it's the round knob at the end of a bone. You have two condyles, medial and lateral, and they define the medial and lateral compartments. So there's actually three compartments in the knee: medial, lateral, patellofemoral compartment. Here I'm putting the tibia back in so you can see the relationship. And we can look at the femoral condyles. This is an anterior view. This is a lateral view. This is a posterior view. And I want to point out that between the condyles is this intercondylar notch. That's where your cruciate ligaments live. And by putting the tibia back in, you can see the relationship. You can see the lateral compartment and the medial compartment. Looking at the articular surface in the tibia, as opposed to the round articular surface of the femoral condyles, the tibial articular surfaces are flat, and we call that the tibial plateau. Plateau is French for plate. Notice between the medial and lateral compartments is this bump here, which we call the tibial eminence, separating the medial and lateral compartments. And there's two little points coming off those, and we call those the tibial spines. And they separate the lateral compartment from the medial compartment. So here's just an example of tibial eminence. Here's a patient who came in January complaining that she hurt her knee skiing, and we can see very nicely the normal intact tibial eminence. Now she came back a few months later after having been knocked down by her dog, and what you can see right here is a fracture through the tibial eminence. And this is not a common fracture, but it's certainly a fracture to look for. It's a transverse horizontally oriented fracture, so we know that this is an avulsion fracture, as we've talked about in past lectures. So what this actually represents is an avulsion of the anterior cruciate ligament. The anterior cruciate ligament inserts into that tibial eminence, and while many people will tear their ACL, occasionally you'll have this avulsion injury, and that's actually, in the grand scheme of things, not a bad injury to have, because they can screw down this tibial eminence and the ACL itself is still intact. So let's talk about imaging the knee. Radiographically, we use radiographs about 78% of the time, and it's certainly the primary modality for imaging knee pain. It's very good to look for arthritis, like joint space narrowing and osteophytes. It's very good for looking for fractures or loose bodies. MRI is the second most common thing we do. About 21% of the time we're imaging the knee with MRI. It's really the best way we have for looking at internal derangement, ligament meniscal tears, cartilage defects, as well as occult fractures. We do not miss fractures by MRI. CT, very rarely used in the knee, mostly used for surgical planning of fractures we've already seen on radiographs. So let's look at radiographs. This is Marty again, and this is how we shoot the knee. We like to shoot them standing upright, and we get the straight AP view like this, which radiographically looks like this. The AP view is very good because it shows the widths of the lateral and medial compartments. Very good for assessing for arthritis. The problem with the AP view is it doesn't show that third compartment, the patellofemoral compartment. But it does very nicely show the articular surfaces. It shows the weight-bearing portions of the femoral condyles and the tibial plateau. And it's very good for looking for displaced fractures. Now this is the lateral view. We also shoot this standing, and it looks like this on a 3D model. And here's what it looks like radiographically. The lateral view shows the femoral condyles and the tibial plateau. It doesn't really show the widths of the medial and lateral compartments because of a lot of overlap, but you're going to see that much better on the AP view. One of the best things about the lateral view is it gives you a good lateral view of the patella. And this is very good for looking for patella fractures. But this view doesn't really show you the patellofemoral compartment. You don't know how deep within that trochlear groove the patella is sitting. Now, a lateral view can show a sizable joint diffusion, a large joint diffusion, but I wouldn't rely on your radiographs. Your physical exam is going to be much more sensitive for joint diffusions than radiographs. Now, it's important to get this third view, the sunrise view, which is also known as a Laurent view. Here we have the patient bend their knees, and the X-ray beam comes over the top, so it kind of looks like the patella looks like a sun rising over the mountains, the sunrise view. And this is an important view because this is the only view that shows the patellofemoral compartment. And it's very important to assess for arthritis. It shows alignment between the patella and the trochlear groove. And you want to see the patella sitting very nicely in that trochlear groove, just like that. A fourth view that we often get is called the notch view or the Rosenberg view. And that can be shot with the patient crouching or with them laying on the table with them bending their knee. And this gives you this view here, like you're looking up into the intercondylar notch. And the nice thing about the Rosenberg view is it shows the widths of the posterior lateral and medial compartments. So it shows arthritis really in the posterior weight-bearing portions of the joint. Again, it doesn't show the patellofemoral compartment. That's why you need that sunrise view. And again, this does show articular surfaces. It shows the posterior portions of the femoral condyles and the tibial plateau. And we use this view to look for displaced fractures. So let's talk about fluid in the joint. When you have fluid in the joint, it's called an effusion. And that effusion could be any type of fluid. It could just be simple synovial fluid, like from inflamed synovium. For example, from arthritis, osteoarthritis, rheumatoid arthritis can give you synovial fluid. It could be blood in the joint, and if there's blood in the joint, we call that a hemarthrosis, basically a bloody joint effusion. And that's usually due to a torn vascularized structure like the anterior cruciate ligament. The anterior cruciate ligament has a good blood supply. If you tear that acutely, you expect to have a bloody joint effusion, a hemarthrosis. Now, a whole different thing is you can have fat and blood in the effusion, in which case we call it a lipohemarthrosis. Fat and blood, lipohemarthrosis. And that's important because the only place the fat can come from is the fatty yellow bone marrow inside the bone. So anytime you see a lipohemarthrosis, that tells you that there's an intra-articular fracture, because the only place the fat could have come from is from the bone marrow. Now let's show where fluid can collect. The knee can hold a lot of fluid, but it doesn't tend to accumulate between the articular surfaces. Joint effusions in the knee collect in the suprapatellar pouch. This is a synovial line space, and it's a normal expansion of the joint capsule. It can easily hold more than 40 mLs of fluid. Here's a lateral view, and I think you can see very nicely this large joint effusion on this lateral radiograph. So if there's a large effusion, I can see it on a radiograph. Here's another patient, and I'm really not seeing any effusion, at least radiographically. I'm not seeing that ovoid soft tissue mass filling up that suprapatellar pouch. So while radiographs can show sizable joint effusions, your physical exam is still more sensitive. You shouldn't be ordering radiographs to assess for joint effusion. You should be examining the patients to assess for joint effusions. So here's a patient. I can't really tell in this lateral view if they have a joint effusion or not. Again, radiographs are fairly insensitive for fluid. If you really need to know, MRI doesn't miss fluid. We talked about T2 weighted image, especially T2 with fat suppression, very nicely shows fluid. And here we can see the joint effusion in the suprapatellar pouch. You can also see a little bit of fluid joint effusion between the articular surfaces. Notice on the proton density weighted image, that's that same slice proton density. Proton density doesn't show the fluid nearly as well as the T2 weighted images, and that's one reason we rely a lot on T2 weighted images when it comes to MRI. Now, if we take an axial image through this joint effusion, you could see that the suprapatellar pouch actually wraps around the femur. It kind of hangs down like saddlebags. So my PowerPoint model should actually look more like this, the suprapatellar pouch wrapping around the femur. So this is a sagittal slice through the lateral compartment of the knee showing the joint effusion. Here's a sagittal slice of that same patient through the medial compartment. You can again see the joint effusion in the suprapatellar pouch, but look back here. There's additional fluid back there, and that's in a Baker's cyst. A Baker's cyst, also called a popliteal cyst, is another place where fluid can collect. Remember, the suprapatellar pouch is a synovial line space, a normal place for fluid to collect. The Baker's cyst is also a synovial line space, but it's an abnormal place for fluid to collect. It represents a posterior extension of the joint capsule, and it's medial. Baker's cysts always occur in the same location. They arise medially between the medial head of the gastrocnemius muscle, which is one of the calf muscles, and the semimembranosus tendon, which is one of the hamstring muscles. So the way to keep the Baker's cyst straight is remember medial, M. Medial gastroc, semimembranosus, MM, that's your Baker's cyst. So here we can see that anatomy very well on MRI, even better seen on a proton density weighted image. This is the medial gastrocnemius muscle. Here's the tendon going up to originate above the femoral condyle. Here's the semimembranosus muscle. Here's its tendon coming down to insert below the tibial plateau, and right where they cross, that's the weak spot in the back of the knee. That's where the Baker's cyst occurs. You can see this anatomy on the coronal images as well. Here I'm showing you the medial gastrocnemius on both proton density T2, and I'm drawing it in on the 3D, as opposed to the lateral gastrocnemius. The gastroc has two heads, two bellies, if you will, medial and lateral. But here's the semimembranosus tendon coming down, and right between them is where the Baker's cyst occurs, between the semimembranosus and medial gastroc. Right there, the Baker's cyst. Now, another space that fluid can collect is in the prepatellar bursa. This is also a synovial line space, but this does not communicate with the knee joint capsule. So this is an unusual place for fluid to collect. Normally, the prepatellar bursa contains little or no fluid. It's more potential bursa than a real space. But irritation of this bursa can cause marked increase in fluid in this prepatellar bursa. And prepatellar bursitis is reported in people who kneel frequently. It's been called housemaid's knee or preacher's knee. Frankly, prepatellar bursitis is often diagnosed by physical exam. Here's a picture that I stole from Wikipedia showing this patient with this huge prepatellar bursal fluid. And you might be able to at least suspect it on radiographs. Here's a patient that has an awful lot of swelling of their prepatellar soft tissues. But you really need an MRI or maybe an ultrasound to show that it's actually contained fluid collection. Now, one thing we're always looking for in these joint diffusions is loose bodies. A loose body can be a fragment of bone or cartilage within the joint capsule. It can be a loose osteochondral fragment. Now, these loose bodies may be inconsequential as long as they stay outside of the joint. If they remain in the suprapatellar pouch, or if they get trapped in the Baker's cyst, they're not a big deal. They just sit there and don't bother anybody. But if they get stuck between the articular surfaces, they may cause locking or even destruction of the articular cartilage. So here's a patient with a lot of bodies in their joint. You can see quite a few of them. I think they're in the suprapatellar pouch. I don't really know from a radiograph. Here's a few more back here. I'm not sure where those loose bodies are. MRI very nicely shows all of this. You can clearly see these large loose bodies. They're in the suprapatellar pouch. Here's a big Baker's cyst, and here's some loose bodies back there in the Baker's cyst. We can actually see this anatomy even better on a proton density weighted image, which doesn't show the fluid as well, but does show the loose bodies, and that's why we like to have both the T2 and proton density weighted images side by side to sort out all this anatomy and pathology. This patient also has a lot of osteophytes arising from their knee, so they've developed arthritis either before or after they got these loose bodies. Now here's a younger patient, 23-year-old male, and this is the reason why we always like to get radiographs before we jump on advanced imaging. Clearly this patient has a loose body in the anterior aspect of the knee joint. This is a place we worry about them. Here on the AP view, you can see this loose bodies in the medial compartment. So they sent this patient to MRI just 1 week later, and now look what happened. The loose body is now in the lateral compartment. This loose body is really loose, moving around in the knee joint. This is a bad thing because it's scraping up against that soft articular hyaline cartilage. We got to fish that loose body out of there through arthroscopy. Patient also has another loose body up here in the suprapatellar pouch. That one we're not so worried about. Now let me just show you this here. This you do not want to call a loose body. This is a fibella. Fibella comes from Latin meaning little bean, and it's just a normal sesamoid bone. It's a sesamoid bone in the lateral gastrocnemius muscle. It's present in about 10 to 30% of people. It's often bilateral. Here's that patient's other knee. Here's their fibella on the other side. The only significance of a fibella is not to call it a loose body. Otherwise, it's really just nothing. Okay, so now let's talk about fractures. Fractures of the patella are fairly uncommon. They can either be due to direct trauma, like someone falling on their patella, or from distraction, pulling the fragments apart. Fractures of the femur, the femoral condyles, are fairly rare, whereas the fractures above supracondylar or between intracondylar are more common. And I'm going to also show you osteochondral defects that are fairly common. But the most common fracture is the tibial plateau fracture, very common, particularly from motor vehicle accidents. Now, I started out showing you some normal knees, and I showed you this notch view and this AP view and even this sunrise view. And those of you who may have been astute were saying, how come I didn't mention this patella fracture right there? Because it turns out this is not a patella fracture. This is a bipartite patella, and the patient has a little one on the other side as well. Bipartite patella is a common normal variant. It's in about 2% of the population, much more common in boys than girls, about half the time bilateral, and it's almost always asymptomatic. The biggest thing is not to confuse this with a patella fracture. It's just a bipartite patella. And the way I keep it straight is it's always superior lateral in the upper outer quadrant. That's where they always occur, superior lateral. Now, patella fractures themselves are uncommon, They can be due to direct trauma like fall on a knee, and in which case they tend to have a comminuted stellate pattern. But typically these are not distracted. All of the fragments stay in place in that extensor mechanism. Here's an example here. It's a little hard to see on the AP view, and the patella is hard to see on the AP view because it overlaps the femur. But you might be able to see this fracture of the patella. Here's the lateral view, and it's hard to see here because it's so non-displaced, but there is a patella fracture. And actually, this is an example where the sunrise view best shows us this comminuted but non-displaced patella fracture. Now, another mechanism is due to indirect distracting injuries. If you have an unexpected rapid knee flexion against a contracted quadriceps, you can actually distract the upper and lower poles of the patella, basically splitting the patella in half. And here's an example of that, distraction of the patella. These require a big operation because the quadriceps is a really strong muscle. So you have to go into the operating room, squeeze the pieces together, put not only wires but screws across this to really hold the whole thing together. They do this figure of 8 tension wire to keep these pieces of the patella together. Now, regarding femur fractures, you can have a condyle fracture, but they're actually very rare. What's more common is to have a supracondylar fracture or an intercondylar fracture. Femoral condyle fractures are uncommon, and they result from shearing of the condyle as the femur is dislocated across the tibia and then relocates, causing a fracture like this. Here's an example of one. The AP view, it's hard to see anything, but on the lateral view, I think you could see this fracture shearing through the femoral condyle. And all of these are going to get worked up with CT scan for surgical planning to show that fracture, the condyle fracture. What's more common is the super and intercondylar fractures. These are caused by axial loading, with the femur being driven into the tibia. You can get a fracture between the condyles, we can get a fracture above the condyles, or you can get both. And these are found to be increasingly common in the same population we've talked about. We see them in older females from low energy injuries because women are osteoporotic, and we see them in younger males from high energy injuries because young males are idiots. So here's an example, 49-year-old female, and you could just see this terrible impacted fracture above and between the femoral condyles, with the femoral shaft impacted into and between the condyles. Here's when they put traction on him, trying to restore things to the proper length. We do a CT scan for help with surgical planning, and you could just see where all the fractures are. Now, this is a condition you will definitely see. This is fairly common, particularly in adolescents and young adults. And if we look right there, there's a fracture of that femoral condyle, and we call this an osteochondral defect, or an OCD. It's a fracture of the bone, which is why we call it osteo, and it's a fracture of the cartilage, which is why we call it chondral, osteochondral defect, or osteochondral fracture. In adults, these are almost always due to trauma, but in children, they can be due to no reason. They're just idiopathic. In children, we may want to call it osteochondritis dissecans, as a disease that we don't know what causes it. These are particularly common in the femoral condyles, medial condyle, 4 times more common than the lateral condyle. We're going to do a lot of imaging with these. We're very aggressive with treating these, but like everything else, you're going to start with radiographs. Here you can see that osteochondral defect. And then at that point, you may want to get a CT, because CT well shows the corticated margins at this donor site. Or you may want to get an MRI, because MRI gives you idea of whether it's stable or unstable. But frankly, these should be ordered by the orthopedic surgeon who's treating the patient rather than by the primary care provider. But I think the best way to image osteochondral defects is with MRI, because you can see them, you can follow them, you can see if they're becoming stable or unstable. Here's a coronal T1 weighted image. You can see the osteochondral defect. Here's a T2 weighted image. There's the lesion. Here it is on sagittal. We can see where the lesion is, see a little bit of defects at the cartilage. This was felt to be an unstable lesion because of the cysts around it. So they took this patient to arthroscopy, and that whole piece just fell out of place. And here they are screwing it back in place. And here's the final radiograph with that piece screwed in place. Hopefully it will go on to heal nicely. But most of the fractures that I see on a day-to-day basis are tibial plateau fractures. These are very common. 80% of the time they're from motor vehicle accidents, the rest from fall or from sports, and they usually involve the lateral tibial plateau. And these all get worked up with CT for surgical planning. I'm just going to mention there's a whole Schatzker classification system. I don't memorize it. I don't think you have to memorize it. I just built this slide so I know where to look it up. So here's an example. 46-year-old physician injured his knee skiing. Actually walked around with knee pain for 4 days because he didn't think it was anything too bad. When he realized it was not improving, he went on to get imaging, and here's his radiograph. And what he has is one of these tibial plateau fractures, a Schatzker type 2. He then went to MRI, probably should have gotten a CT first, but he wanted to get an MR, and the MR really shows this whole disruption of that whole lateral tibial plateau. But frankly, the CT is a better way to see this, because the CT really helps with surgical planning. You can see that fractured fragment being impacted down into the femur. We can even do fancy things with CT. We can get a rotating three-dimensional model to show the anatomy. I can actually disarticulate the other bones. I can roll this up and look down into it to see that impacted articular surface of the lateral tibial plateau. I'll do whatever the surgeons need to help do their planning. Here's the patient's intraoperative photographs. Ended up having a big operation where they had to put all these wires in, put this lateral plate in there, put some bone cement in there, and this is what they needed to do to fix this very complex fracture. What about non-displaced or occult fractures? Basically, the way we diagnose fractures on radiographs is to see displaced fragments. But non-displaced fractures can be radiographically occult. So how do we detect an occult knee fracture? CT really doesn't help with this. Fractures that are non-displaced by radiographs are non-displaced on CT. Certainly you can get MRI. MRI does not miss non-displaced fractures. But you can't send every ER patient with knee pain to MR, so we have to have some other criteria, and there's a trick to seeing occult fractures. Remember, in the elbow, the trick to see a radial head fracture was to look for those elevated fat pads, an indirect sign that there was a fracture. This is a similar trick, and this is to look for the lipohemarthrosis on a cross-table lateral. Now that's a complicated sentence. Let me explain what it means. I've already showed you how we shoot radiographs in the clinic. We shoot the AP and lateral views with the patient standing. We like to do weight-bearing views. But in the ED, patients are often in pain. They're not standing. So we shoot them with the patient laying on the cart. So for the AP view, we just have a vertically oriented X-ray beam, and that's how we shoot the AP view. Now for the lateral view, there's actually two ways we can shoot the lateral view in the ER. One way is to still have a vertically oriented X-ray beam, have the patient rotate their knee out, and get the lateral view. But this is not the way we recommend doing it. The problem with this, as I'm going to show you, the X-ray beams are parallel to gravity. This is the way we shoot our lateral views in the emergency room. Patients laying in the cart, we call this a cross-table lateral view. It's a horizontal X-ray beam going cross-table. We put the X-ray cassette between the patient's knees. The advantage of this is now the X-ray beam is perpendicular to gravity, and our policy here at the UW is all ER knees are shot cross-table lateral because we can use a trick to see the occult fracture. Now, I've already talked to you about types of joint effusions. Synovial fluid versus hemarthrosis versus a lipohemarthrosis. Let me do a thought experiment. This is a test tube, and I'm going to fill it up with whole blood. Now, if I just shoot X-ray beams through that test tube, all I'm going to see is gray, because the blood looks all the same to the X-rays. Now, let's take that same test tube, fill it up with whole blood, and wait a few minutes. And what's going to happen if you wait, the blood's going to start settling out. The cells are going to settle down to the bottom. The plasma is going to float to the top. Now, if I take a radiograph, shoot X-rays through this, I'm still just going to see gray, because plasma and cells have the same exact density to X-rays as each other, so I can't tell a difference. So I can't tell a simple joint effusion from a hemarthrosis, a bloody effusion. But let's do this now. We take that same test tube, and now we're filling it up with a lipohemarthrosis. And we let this sit for a couple of minutes. And what's going to happen is the cells are going to go to the bottom, the plasma is going to come to the middle, but the fat, the fatty yellow bone marrow, the fat is going to float to the top, just like my grandmother's chicken soup, the fat floats to the top. Now if I take an X-ray of this, what's going to happen is I'm going to see this, that the fat has a different density than the plasma in cells. I can see this fat fluid level. But this only works when the X-ray beam is perpendicular to gravity, which is why we need that cross-table lateral. But this is what a lipohemarthrosis looks like on a cross-table lateral. That fat is the blacker stuff above the fluid, which is the gray stuff. And that horizontal line, that's the fat fluid level. That tells me, just like in my test tube, that there's a lipohemarthrosis. And the lipohemarthrosis is telling me that there's an intra-articular fracture. So this is a good way to see these occult, non-displaced fractures. Look for the lipohemarthrosis on a cross-table lateral. Now, normally we display the images like this, even though we shoot them cross-table. Don't let that bother you. So here's a patient that really the AP and lateral views don't show a fracture very convincing, but they do show the lipohemarthrosis. If we magnify up on this, maybe there's a subtle displaced fracture, hard to see, but now that I know it's there, I think I can see it. So the fact that I can see the fracture on the radiograph, that's a good patient to send to CT. If I can see it on a radiograph, it's displaced enough that it will show up on CT. It's not very displaced, but it's at least enough to know what we're dealing with. That slightly depressed lateral tibial plateau fracture. This is one of those Salter-Harris type 3 fractures, and this CT was very helpful to the surgeon. Here's the sagittal view, just showing the slight amount of depression of that fracture. And here they are intraoperatively, and they're doing this all under fluoroscopy without actually opening the knee joint. They're kind of doing this from the outside. Here's that little depressed fragment, and you can watch they're slowly elevating that fragment up, and then they just ended up fixing this with just 2 screws and some bone cement without actually going into the knee joint, and this is why CT was really helpful in planning how to do this operation. But this is a real occult fracture. The AP view, I don't see a fracture. The cross-table lateral view, I don't see a fracture. Aha! But I do see that lipohemarthrosis. I know there's a fracture there. This patient, I suggest, should not have gone to CT, but the ED has a CT scanner right there, so they send him to CT. And the problem with this, such a non-displaced fracture, is the CT is not very convincing that there is a fracture. No surgeon is going to operate with that CT. So those occult fractures, the ones you can't see on radiograph that are non-displaced on CT, those go to MRI, and MRI very nicely shows you on this fat-suppressed T2 weighted image the bone marrow edema at the fracture site, as well as this T1 weighted image actually shows us black fracture lines, this minimally impacted or basically non-displaced occult lateral tibial plateau fracture. Okay, I now want to move on to ligaments and tendons, which is the main reason you guys are going to be getting MRI. Tendons connect muscles to bone, and ligaments connect bone to bone. We've already talked about the quadriceps. We talked about the quadriceps tendon, and a lot of people consider this whole structure to be the quadriceps tendon. But that just basically has the patella just being a sesamoid bone without being a bone on its own right. Frankly, I think the patella is a real bone. So personally, I divide this into a patella ligament connecting bone to bone and a quadriceps tendon connecting muscle to bone. But you can use either terminology. We have other ligaments inside the knee joint like the anterior cruciate ligament and the medial collateral ligament. But before we show you those, I want to talk about quadriceps tendon ruptures. Most quadriceps tendon ruptures occur at patients over the age of 50, men more common than women, and these are transversely ruptures right at the patella insertion. You're going to diagnose these on physical exam. The patella is going to be freely mobile, and the patient is going to be unable to actively extend his knee. He's still going to be able to flex his knee, he just can't extend his knee. Radiographically, what you may see is a low riding patella. We call that patella baja, low patella. That's like Baja California, that piece of California that sticks into Mexico. Here's an example in MRI of a quadricep rupture. You can clearly see disruption of the quadricep tendon on a proton density weighted image, and you can see a big fluid gap in there on a T2 weighted image. We're not going to miss quadricep ruptures on MRI. Similar to a quadricep rupture is a patella ligament avulsion. These tend to occur in people under the age of 40 and most commonly in people of African descent. And these are also transversely oriented, but these occur below the patella at the origin of the patella ligament off of the patella. Similar exam, patient is going to be unable to actively extend their knee, and radiographs are going to show a high riding patella, what we call patella alta. Here's a trick on how you can determine if the patella is normal in position or not. If you look at a lateral radiograph, normally the length of the patella is equal to the length of the patella ligament plus or minus 20%. So in patella alta, the patella ligament, which I'm measuring is this long, is more than 20% longer than the length of the patella, which is this long. So this would be an example of patella alta. Now, patella alta doesn't mean that you have a patella ligament avulsion. That just may be the way the patient is. But you want to start thinking about it. You want to examine them, see if they can extend their knee, see if their patella is freely mobile. This is an example of a patella ligament avulsion. You can see the big gap on both the proton density and T2 weighted images. The ligaments inside the knee joint, you have a medial collateral ligament, your MCL, that goes from above the condyle to below the patella. You can see that very nicely in MRI, a nice black structure, the medial collateral ligament. The MCL is frequently injured from for example, from a lateral clipping injury that puts a valgus stress on the knee. You can actually tear off the medial collateral ligament, and that's what we're seeing in this patient here. You can see the MCL is all wavy, and it's not actually inserting into the tibia. That's a MCL tear or avulsion. Laterally, you have three structures you need to know about. You have the iliotibial band, and that shows up very nicely on MRI. You have the biceps femoris tendon with the fibular collateral ligament that both insert on the fibula, and we can see those as well. Here's the fibular collateral ligament. Here's the biceps femoris tendon. Frankly, these lateral collateral complexes infrequently injured. I look at it in every MRI, I report on it, but I don't see a lot of injuries of these things. Now, cruciate ligaments. This is where things get interesting. Cruciate comes from Latin to cross, and the anterior cruciate ligament crosses anterior to the posterior cruciate ligament. If we look inside the knee like this, we can actually see where these ligaments run. The ACL runs from the lateral femoral condyle to the medial tibial spine. The PCL runs from the medial femoral condyle to the lateral tibial spine. I know that's confusing, but there's a trick. If you take your fingers, cross them, put them on your knee, The anterior ACL's in front. The ACL runs lateral to medial. The PCL runs medial to lateral, unless you cross your fingers backwards. Now the cruciates cross in both planes. They cross in the AP plane, but if we look at it from the side, in the sagittal, they cross here as well. Here's a CT scan. It's kind of hard to see the ligaments here, but I'm just showing you the anatomy. The ACL runs like this. The PCL runs like this. MRI is really the way to see these ligaments. ACL running like this, PCL running like this, crossing in both the frontal and sagittal planes. Cruciate ligament tears. The PCL infrequently tears, and even surgical reconstruction of a PCL tear is controversial. But the ACL frequently tears. It does require surgical reconstruction. We see this all the time in sports related to twisting injuries. And when you tear your ACL, it allows anterior displacement of the tibia relative to the femur. We call that the anterior draw sign. You guys know about the anterior draw sign? Yes. So here's the way the anterior draw sign works. When you have an ACL tear, your tibia gets dislocated anterior relative to your femur. Now, we don't usually see that on radiographs, but I just happen to have a radiograph of somebody whose tibia is anteriorly displaced, anterior drawn. This patient definitely has an ACL tear. More commonly, we can actually see this anterior draw sign in MRI, where the tibial plateau is just shifted forward in front of the femoral condyles. Now, kissing contusions occur when you have this transient anterior dislocation of the tibia. The back of the tibial plateau impacts upon the front of the femoral condyle, causing bone marrow contusions and edema in both sites. And even when you relocate the knee, that contusion persists. And we see this all the time on MRI, particularly on the T2 weighted image. There's bone marrow edema in the anterior femoral condyle, bone marrow edema in the back of the tibial plateau. T2 weighted images are very sensitive to fluid, very sensitive to these kissing contusions. The proton densities are less sensitive to fluid, but it does show there's a black fracture line actually showing us impacted fractures at these sites. And you can get real impacted fractures there. When this impacts, you can have impaction fractures of both the anterior lateral femoral condyle and the posterior lateral corner of the tibial plateau. And when they relocate, you'll still see those fractures. As in this patient here, has not only bone marrow edema, but an impacted fracture of the medial of the femoral condyle and an impacted fracture of the posterior lateral corner of the tibial plateau. Now, what about seeing ACL tears at MRI? I've showed you the indirect signs. I've shown you the anterior draw sign, the kissing contusions. Those are the indirect signs. The direct sign is hard to show because it's non-visualization. So the way I show you an ACL tear is show you an ACL that's not there. So just as a reminder, here's a normal knee, there's the intact ACL, here's somebody with a torn ACL, you just don't see an intact ACL. That's how we make the diagnosis. We are very accurate with ACL tears, over 95% accuracy in detecting them with MRI. Finally, menisci. Looking at menisci, I think, is the primary indication for ordering MRI of the knee. Because frankly, to assess for fractures and arthritis, you're going to order radiographs first. For surgical planning of fractures, you're going to order a CT. To assess for an ACL tear, you're going to at least start with your own physical exam. You're going to suspect the ACL tear from your physical exam. But to assess for meniscal tears, radiographs aren't helpful, physical exam isn't helpful, meniscal tear pain is very poorly localized, and that's why we do so many MRIs to look for meniscal tears. Now, the menisci, the function of the menisci is to improve contact between those curved femoral condyles and the flat tibial plateau. There's a medial meniscus and a lateral meniscus, and these are composed of fibrocartilage. They're triangular in cross-section, and they function kind of like O-rings to improve this contact. but they're actually C-shaped. If we take a look at them and we look from the top down on them, that's anterior, that's posterior. If we look down on them, we can see these C-shaped menisci. We can divide the menisci into thirds. There's an anterior horn and there's a posterior horn. And if we take a sagittal slice through the anterior and posterior horns, what we see are black triangles. A black triangle for the anterior horn, a black triangle for the posterior horn. Here's an MRI showing you that exact anatomy. Black triangles, anterior and posterior horn. Anterior horn there, posterior horn there. As we start taking slices more and more to the periphery, these two triangles start getting closer together, until you get to the third part of the meniscus, the mid-body. If you take a slice through the mid-body, the triangles are so close together that they look like a butterfly or a bow tie. But we don't only image in the sagittal plane, it's also very important to image in the coronal plane. And the coronal plane, we very nicely see the mid-bodies, the mid-body of the medial meniscus, the mid-body of the lateral meniscus. They all look like black triangles. Now, how do we define a meniscal tear? Meniscal tears are seen in MRI as increased signal that extends to an articular surface on at least two slices. If we only get it to touch on one slice, we call that a possible tear. And we're not saying that just to be wimpy radiologists. It turns out if we can only find that tear on one slice, the possible tear, when they go to arthroscopy, half of those are torn, half of those are not torn. But if we can get it to touch on two slices, we're very accurate. But it's got to extend to an articular surface. That's important. Here's my black triangle again. That would be the superior articular surface. That would be the inferior articular surfaces. Any lines that go to those surfaces touch the articular surface. But not this. This is the base. That's not an articular surface. That's where the blood supply comes in. But this is the free edge. That is an articular surface. The free edge is that hole inside of the C, and that's what the arthroscopist sees when they look inside the knee joint. We've been trying to use very specific terminology with tears so that us and the arthroscopists are using the same language. So the most common type of tear is a horizontal tear, otherwise known as a cleavage tear. A horizontal tear cleaves the meniscus into upper and lower halves. Here would be a sagittal image showing the posterior horn of the medial meniscus, showing this horizontal cleavage tear through the posterior horn of the medial meniscus. We can see this in the coronal plane as well. Posterior horn of the medial meniscus, horizontal tear going through the entire posterior horn of the medial meniscus. The most common place to tear, posterior horn medial meniscus, but the most common tear, horizontal cleavage tear. A longitudinal tear is also known as a vertical tear. Now, a vertical tear separates the meniscus into inner and outer pieces. If we take a sagittal slice through a tear like this, what you're going to see is a vertical line through the posterior horn, or you may see a vertical line through the anterior horn, or if it's a really big tear like in this patient, you're going to see both. Vertical lines through both the anterior and posterior horns, telling us this is a big longitudinal tear. Coronal image also shows that longitudinal vertical tear extending through the mid-body. And sometimes we actually get lucky on the axial, and you can see the entire length of the tear, this longitudinal vertical tear. Now, a third type of tear is a radial tear. Radial tears radiate from the free edge outward, and they separate the meniscus into anterior and posterior halves. And I think this is the best way to think about tears. A horizontal tear separates the meniscus into upper and lower portions. A vertical tear separates the meniscus into inner and outer portions. A radial tear separates the meniscus into anterior and posterior portions. Now, these can be a little tricky. If you put a coronal slice right through a radial tear, what you may see is just nothing, the absence of meniscus. And that's exactly what we're seeing on this patient here. There's just no mid-body of the medial meniscus. Here's the coronal image showing the lack of the mid-body of the medial meniscus because there's a radial tear right there. Now, when you have these meniscal tears, even worse than just a tear is if a piece of meniscus flips and has a flip fragment within the knee joint. If a meniscus portion is displaced within the knee joint, like this, it can cause locking or at least decreased motion. So in this scenario, you have the whole posterior horn flipping behind the anterior horn, and that's exactly what happened to this patient here. Here's the normal anterior horn in the normal location. Here's the posterior horn of the lateral meniscus that should be back there, but it flipped into the anterior half, making it hard for this patient to fully extend his knee. And the last thing I want to show you is a bucket handle tear. A bucket handle tear is a longitudinal tear where the inner portion flips into the intercondylar notch underneath the PCL. So it kind of looks like this. It's been called a bucket handle tear because it kind of looks like the handle of a bucket if you turn it on its side. So let's look at a bucket handle tear, and it's really helpful to compare that to the normal meniscus on the other side. If you take a coronal image, you're going to see the intact mid-body of the lateral meniscus, you're going to see the torn mid-body of the medial meniscus, and the bucketed portion of the mid-body of the medial meniscus. And that's exactly what we're seeing on these coronal slices here. Intact mid-body of the medial meniscus, torn, very small mid-body of the medial meniscus, bucketed mid-body of the medial meniscus, flipped underneath the posterior cruciate ligament. One more example of the same thing. You could see the normal mid-body of the lateral meniscus. You could see that little tiny torn mid-body of the medial meniscus. Here's that big bucketed mid-body of the medial meniscus underneath the PCL. And if we do a sagittal slice through this, you get this interesting picture here where you see the normal PCL and this bucketed mid-body of the medial meniscus sitting right underneath the PCL, looking like a second PCL, and we call this the double PCL sign, and a double PCL sign is a clue that there's a bucket handle fragment. So that's what I wanted to share with you today regarding what to order when. We always start with radiographs. We're going to use it to diagnose arthritis, to assess progression of the arthritis, to look for joint space narrowing and osteophytes. You're going to use this to diagnose fractures as well as to follow fractures, assess healing. We're going to look for fracture displacement, intra-articular involvement. Certainly get radiographs to look for loose bodies to see if the body moves with time. And you want to screen for unexpected findings like tumors or metal foreign bodies. It's real embarrassing to put somebody in the MR scanner and not realizing they got metal in their knee. So always get the radiographs. That's what you start with. You need to get at least 3 views. You're going to get the AP that shows the medial and lateral condyles, plateau, and compartments. You get the lateral view that's perpendicular to the AP view that shows the patella very nicely. And don't forget, in the ER, you want that to be a cross-table lateral because you want to see that lipohemarthrosis. Don't forget about the sunrise view. Very important view. Best view of the patellofemoral compartment. You can stop there. If you want to be very complete, you can get the notch view, part of a 4-view series, shows the posterior condyles, good for looking for early arthritis. MRI we frequently order for knee pain, looking for internal derangement, meniscal tears, ligament tears, cartilage defects. Very good for occult non-displaced fractures. MRI does not miss fractures, but I think it really should be ordered by the knee specialist rather than the primary care provider. Because the specialist may want certain sequences, they may prefer certain MR scanners. They're the ones treating the patient. They should be ordering that study. CT is very infrequently ordered for knee pain. Primary use is in the ER to assess the alignment of fracture fragments already shown on radiographs to aid in surgical planning. These should be ordered by the surgical team. Occasionally, for patients who are not MR compatible, we'll do an arthrogram CT in which we inject contrast into the joint and do a CT scan. Again, should really be ordered by the knee specialist. Any questions about the knee? Okay, thank you.